Good evening, everyone. We're just going to give it a minute while people come into the room. Um, okay. So good evening, everybody, and thank you so much for joining us on this webinar. Before we begin, I just want to acknowledge that I'm located in Ottawa. My name is Helen Crawford. I'm the Senior Programs Manager here at Psoriasis Canada. I'm located in Ottawa, which is the unceded and unsurrendered territory of the Algonquin Anishinaabe people, and we acknowledge that the Anishinaabe Algonquin Nation have lived on this territory for millennia. And we welcome all of you from wherever it is that you're joining us from today. So we're just do a few brief housekeeping items before we get in. So if you are joining us and wish to listen in French, all you need to do is toggle down to the bottom right and click on the interpretation button and select French. And we have a translator who will be sharing all this information simultaneously with you. The webinar is being recorded in both English and French and will be posted shortly after the session within the next day or two to our YouTube channel. All of you are currently in listen-only mode. This session is being recorded, so you're just able to listen. And if you do have any questions that we'll get to at the end of the presentations, you can put them in the chat or in the Q&A section at the bottom of your screen. And we just want to make sure that you're aware that all the webinars and our resources that we provide are for information purposes only, and is general information provided to you. And if you have any personal or specific questions or concerns, you should speak directly with your doctor. And before we get started, we just want to make sure that we thank all of our sponsors who supported our World Psoriasis Day activities over the last week and a bit, and they're listed on the screen: AbbVie, Arcutis, J&J, Eli Lilly, Sun Pharma, and UCB, without whom we couldn't make any of these webinars possible. So as some of you may be aware, just as a brief background, Psoriasis Canada, although is a relatively new organization operating in Canada, it actually came from a history of more than 15 years of experience, wherein two national psoriatic organizations that were operating in Canada since 2012 made the decision to consolidate to form one large national voice for people living with psoriatic disease in Canada. We recently developed our strategic plan, which is kind of guiding our activities and such over the next 3 years. So this webinar is a third in a series that we've done for World Psoriasis Day. And as you might know, World Psoriasis Day actually occurred last week on October 29th. And on that day, every year, people around the world come together to raise awareness about psoriatic disease and to support the psoriatic disease community. This year's theme was comorbidities, and in particular about stopping the domino effect. And comorbidities is basically other health conditions that you can be at risk of if you're living with psoriatic disease. Not necessarily will be impacted by, but something that our community needs to be aware of, that there is a possibility. As part of our World Psoriasis Day activities, we also launched an educational social media campaign that's now finished. But if you follow us on social media at Psoriasis Can 1, you can go back and take a look at the highlights of that campaign. It's based on a survey that we did in the summer of our community, asking them about their understanding and perceptions of the associated conditions of psoriatic disease. And from what we learned there, we based our webinar series as well as that social media campaign. The webinars themselves, as I said, this session is part of a series of 3 webinars. You can go to the next slide, Antonella, please. That focused on some of the main conditions that we know are associated with psoriatic disease, in particular psoriatic arthritis. We hosted a webinar with a rheumatologist, Dr. Vinod Chandran. And then we also last week did a webinar with Dr. Marlene Dietok who is a dermatologist with a specialty in psychodermatology on the mind-skin health connection. And if you're interested or missed any of those, they are on our YouTube channel in both English and French, so you can watch them there. And again, it's at Psoriasis Can 1 on YouTube. So just to encourage everyone to keep in touch with us, if you'd like to stay up to date on our activities, we post everything to our social channels, all of our events and activities and awareness campaigns, again, at Psoriasis Can 1. Our email address is there, and we are in the process of launching a new website, which should be coming within the next couple of months, hopefully, which will be www.psoriasiscanada.ca. You can also go there to sign up for our newsletter that we try to send out every other month or so. And finally, before we jump into the main subject matter of tonight, we just wanted to let you all know of an online support program that we offer. The next one is coming up on November 19th. It is a small group that come together online that is facilitated with a trained facilitator who's also has lived experience with psoriasis. We keep the numbers relatively small, so the QR code is there if you'd like to register for the next one. It's a pilot program right now, and we're looking at ways in the new year to expand the program to include sessions in French, as well as regional or perhaps theme related. So with that, I wanted to turn it over to our subject for tonight, which is psoriasis and cardiovascular disease. I mentioned that the survey we did this summer, where we asked people about their perceptions and understanding of the conditions that are most commonly associated with psoriasis, we found that while 72% of the people we talked to, and we did hear back from over 300, 72% of them were aware that psoriasis could be associated with other conditions. However, less than 30% of people knew that cardiovascular disease was one of those associated conditions. We were also learned that 73% of the people that we surveyed felt that they weren't well informed or had enough information about the potential risks that were associated with psoriatic disease. And that was why this webinar and the other two came to be. We wanted to address and hopefully provide some information and awareness so that you know what you need to look for. So tonight, we're fortunate to have a psoriasis patient with us who will share her firsthand experience on how cardiovascular disease has impacted her, as well as a cardiologist who's going to teach us about the connection between cardiovascular disease and psoriatic disease. So with that, it's my pleasure to first introduce Margaret Peters. Margaret is a psoriasis patient who was a bartender and had a customer see the psoriasis on her hands and refused to accept a drink from her. And so that experience motivated her to create Unmasking Psoriasis, which is an organization that operates in Saskatchewan that was with the intent to raise awareness about psoriatic disease. And did she just fall off the call? I don't. I'm just going to see what happened to her. She was there a second ago. Okay, I think maybe then if she might be having some technical issues, so maybe we'll do this in reverse, and we'll get to Margaret's story perhaps once she jumps back on. So we'll skip to Dr. Janine Eckstein, who is here with us. She's an interventional cardiologist in Saskatoon. She also serves as medical director of the Structural Heart Program, is the director of the lab at the Royal University Hospital, and assistant professor of the University of Saskatchewan. She's earned both her undergraduate and medical degrees at the University of Saskatchewan, where she's also completed her residencies in internal medicine and cardiology. She then pursued a clinical fellowship in interventional and structural cardiology at St. Michael's Hospital in Toronto. She has been a strong advocate for improving access to valve disease treatments in Saskatchewan, and her efforts led to the establishment of the transcatheter mitral valve program and the transcatheter tricuspid valve program in Saskatchewan. Alongside her clinical and leadership roles, Dr. Eckstein continues to pursue her passion for education and professional growth through her current MBA studies at the Rotman School of Management. So thank you so much for joining us. We're very, very grateful to have you here, and I'll turn it over to you.
Thank you for having me. I really appreciate it. Hopefully Margaret can pop back on here, but I'll just share my screen in the meantime while she's finding her way back. That was a lot of, I gave you a lot of really, really hard cardiology words in my biography there.
Yeah,
Sorry, that was,
you did.
all right.
Okay.
So I'm really pleased to talk about cardiovascular disease and psoriatic disease. And I work at Royal University Hospital in Saskatoon and Saskatchewan. And so when we talk about, I thought we'd just start by talking about heart disease in Canada. And so heart disease is the second leading cause of death in Canada. And this is across all comers. And actually, 1 in 12 Canadian adults over the age of 20 have a diagnosis of some form of heart disease, which is quite astonishing because we really think that it's more, it's older people, but we regularly see people in hospital in their 30s and 40s with heart disease. Men are more likely to suffer heart attacks than women, and they're generally diagnosed about 10 years younger than women are, or women are diagnosed 10 years older, depending on how you like to look at it. And 9 in 10 Canadians are actually living with at least one risk factor for heart disease. And many of these are modifiable, which means that they're things that we can manage if we know about them. And so those are things like controlling your blood sugars if you have diabetes, controlling your blood pressure if you have hypertension, controlling your cholesterol, which many people really don't understand how much of an impact that can have, your physical activity level, your diet, your weight, smoking, and also alcohol or drug use. And there's a couple others, but those are kind of the main ones that are modifiable risk factors that we can work on changing, especially if we're aware of them. And of course, not everything is within our control. So you can't control how old you are. You can't control your sex. Your family history is what's been given to you through your genetics. Same with your ethnicity. And inflammatory conditions, as we see in psoriatic disease and some other diseases, are also risk factor that we're given. We don't get to choose, of course. And then there's all the other things that affect us: environmental, financial, the social determinants of health that are so important, and do sometimes tie into some of the modifiable risk factors as well. So when we talk about coronary artery disease, that's what most people think about when they talk about heart attacks and heart disease. And so the coronary arteries are arteries that supply blood and oxygen to the heart. Sometimes we talk about them like the pipes or the plumbing of the heart. And I like to say I'm really just a plumber for very, very small pipes. And if you have blockages, it's called a narrowing or a stenosis. And it's kind of like having a clog in the pipe, like your drain can't drain as well, or things don't get through as well. And it's the most common form of heart disease. You'll sometimes hear it called atherosclerosis or arteriosclerosis as well. And we talk about it in the hospital, at least, and as physicians and healthcare providers, we talk about obstructive or non-obstructive. And so what that means is if your artery is less than 70% blocked, it's actually non-obstructive. It's amazing, but the body compensates very, very well for that. Less than 70% doesn't cause symptoms. It actually doesn't cause stress on the heart, and it doesn't need intervention. You won't benefit from us fixing it. We just want to make sure that it doesn't get worse. And that's because the body is always trying to kind of save itself, and it has some redundancy to help work. If you have a stenosis that's over 70%, that's when we call it obstructive. And that's when we start to get symptoms. And we talk about stable or unstable. And so when we talk about stable coronary disease, that's a stenosis that develops slowly over time. This can cause symptoms when you're exercising or you're putting in effort. And that's often what we hear called angina. And angina is a really big term that people use to apply to a lot of chest pain. But mostly it's supposed to mean that it's chest discomfort that happens with exercise and effort from a narrowing or blockage in the heart arteries. And if you're unstable, that is a whole spectrum of things. They're called acute coronary syndromes, but most of us would know it as some form of a heart attack, whether you'd call it a little heart attack or a big heart attack. An acute coronary syndrome is when something has changed all of a sudden in your arteries and you're having some damage. And when we talk about symptoms, everyone is different, but what you'll see typically in the commercials and on TV and in educational materials is someone holding like a hand across their chest. And so we talk about a squeezing or suffocating, aching pressure sensation in the center to the left of the chest. And we call it pain, but often it's not pain. It really is that pressure, aching, kind of squeezing feeling. It can go into the arms. The left is more common than the right, but it can also be both. It can go up into the neck or the back, the throat, or even the jaw. So some people have told me that they have a toothache every time they go for a walk. you probably aren't having a toothache every time you go for a walk. You can actually get that discomfort up into the jaw. You might also be short of breath. You can have some feelings of nausea. You can throw up, or you can get really, really sweaty. And those symptoms happen with a lot of things. So it's hard for people to know what's going on. And so it's always important to know what you can look for and what your risks are. And I put this in asterisks because women are more likely to experience non-traditional symptoms, but it's actually a little bit of a misnomer. So when we say women experience non-traditional symptoms, we're actually, as women, more likely to experience more symptoms. So women will still have chest discomfort just as often as men do, and it's a vague, pressure, heavy feeling. But women are also more often to have something else along with it. So waking up in the night short of breath and needing to sit up, feeling that nauseous feeling and indigestion, or feeling very anxious. Your body might be trying to tell you that something is going on. And like I said, that chest discomfort plus type of a syndrome. And so when you have stable narrowings, those symptoms tend to be provoked with exertion or stress or effort. And exertion is different for all of us. And then they relieve with resting. And if it's an acute coronary syndrome or a heart attack, they can happen at rest or with stress, but they'll often stay. And so even if they happen at rest, then they'll just kind of stay, and they can stay for minutes or hours. If they're happening with stress and you rest, they often just don't stop. And so that's a sign that you need to seek more help, because it really shouldn't be having that heavy pressure that's lasting. Again, I kind of talked about this before with risk factors, but we look at traditional risk factors. So diabetes, high blood sugars, smoking, obesity or being overweight, physical inactivity, hypertension, which is high blood pressure, or dyslipidemia, which is problems with cholesterol. And those are the traditional ones that most of us talk about. There's also some other ones. And so for women, if you've had preterm deliveries or hypertension or diabetes in pregnancy, those are risk factors. And the one that kind of brings us today is autoimmune or inflammatory diseases are an area where we're learning more and more that it does increase your risk for coronary artery disease. We also have cancer treatments, so radiation, and depression is linked to heart disease, partially because of the medications that we generally take for it. There's some things that have been put out by the Canadian Women's Heart Health Alliance. It applies to men as well, but this one specifically talks about autoimmune disease and your heart. They said it's for men and women, but it's from the Canadian Women's Heart Health Center, so that's why it says her heart. But it talks a lot about rheumatoid arthritis or lupus. But again, any sort of inflammatory or autoimmune disease does increase your risk. And as was noted in your survey, a lot of people knew that there was some other things associated with psoriatic disease, but didn't know what or what the risks really were. And even amongst healthcare workers, I'll have to say that sometimes you do have to be your own advocate, because this autoimmune disease thing, people are just still learning how much rheumatoid arthritis and lupus, as our kind of typical autoimmune disease, affects heart disease. And some people are still kind of having to learn and get on board with the fact that psoriatic disease is also part of that and does cause inflammation and does put you at higher risk. And so this goes through a whole bunch of different things about how autoimmune disease increases your inflammation, and that can cause changes to your blood vessels. And then plaque is what we call when cholesterol deposits in your arteries. And so there's all sorts of things like diabetes and smoking and high blood pressure and inflammation, all of which affect how your body deposits that cholesterol inside your blood vessel walls. And the Heart Health Center really wants to emphasize that part of what you can do is you can be aware of what your risks are and what they are. So if you look at your ABCs, so your hemoglobin A1C, that's your general blood sugar over 3 months. Your B is your blood pressure, and your C is your cholesterol. And getting them tested and knowing what they are is an important way to help support you, knowing what you need to do, and make sure that your doctor is on top of things. Obviously, almost all of us need to move more and sit less, even if that's in small amounts, multiple times a day. Trying to find support to quit smoking and taking medications, which can also help. When we talk specifically about psoriatic disease and other medical conditions, as you guys have had over this series, there are multiple other medical conditions that are associated. And so some of them are depression, which again then creates an area where you have depression, which we know is a higher risk for cardiac disease, and psoriatic disease is also a higher risk for depression. So you can have kind of two of those factors coexisting. Psoriatic disease patients are also more likely to have high blood pressure, which can lead to heart disease. And they're more likely to have cardiovascular disease because of the inflammation. more likely to have diabetes, more likely to have obesity, dyslipidemia. Inflammatory bowel diseases are also more common in psoriatic disease, and some cancers related to the inflammatory bowel disease as well. So we look at it and we know that some of these are things that we already know increase the risk of heart disease, plus we're putting on that inflammatory part. And so it's really important that people know their risk factors. And it's not meant to scare anybody because, as we said, a lot of these are modifiable. We can treat these. We can make these better and we can reduce our risk. We just have to know that we have them and be aware. And so when we look at the risk of having a heart attack, which in the hospital we call myocardial infarction, this is an odds ratio. So for men and women with psoriatic disease, your increased risk of heart attack, so an odds ratio of 2 for men and 3.2 for women. And so that's like saying that you are twice as likely or 3 times as likely, basically, so to have a heart attack. Then when we look at cardiovascular disease and stroke, so that's the one on the right. And so we're looking at both men and women in this, but you're at a 1.7% chance of non-fatal, so having cardiovascular disease, but maybe not necessarily a heart attack, and 1.4 times risk of having a stroke. And so we know these things are really important. And so the severity of psoriatic disease is also related to our risk. You have, by definition, actually a higher risk of hypertension. And so there's actually changes in psoriatic disease that happens in the signaling process, which can make people with psoriatic disease more resistant to medications, or they might require more medications to treat. So if you've ever looked at someone that's a friend of yours that has had high blood pressure and they're on 1 pill, but you're on 4, that actually could be related to your psoriatic disease because it can make it harder to treat. Your duration of psoriatic disease also increases your risk. So if you tended to get it younger, again, you might want to get those risk factors checked earlier. So often we start talking in men about checking blood pressure and cholesterol and blood sugars in the 45 range, and in women more in your 50s. If you know you've had psoriatic disease or psoriasis since you've been younger, you may want to ask for those things to be checked earlier in your life, just so you're getting on top of them. And there is some genetics. We will sometimes see whole families of people that have psoriatic disease, and there's certain genes that are present in people that have psoriatic disease that are also present in people with heart disease. So there's a lot of things that go into this. Like I said, and it's not all of it can be changed. Some of it is things that we do have to be aware of and does increase our risk. And that's why Margaret was going to go first, because she wants to share her story. But we'll still let her afterwards. But like I said, some of it can be changed, and that's really what we want to focus on. The risk scores that we talk about often underestimate the risk. So if you ever go to a doctor, again, sometimes you do have to advocate for yourself. And so when we look at all these traditional risk scores, they're made mostly for people in a North American distribution, and they were made for people with traditional risk factors before we really came to know about inflammatory disease. But there is one score called Reynolds risk score, which integrates CRP, and CRP is a marker of inflammation, so that can help. Otherwise, a lot of the risk scores, they say, okay, we'll take whatever risk score we gave you and times it by 1.5, and that's what we think you are. So again, just kind of a good reason to advocate as we try and get the rest of healthcare providers up to par. It's important to know that you can also be your own advocate. If you've ever kind of looked at some testing, so the testing that we can do for it is something called an echocardiogram. An echocardiogram is an ultrasound of the heart, and it looks at your heart size and how well it's functioning and checks to see if any heart valves are abnormal and can diagnose you with heart failure or valve problems. We look at stress testing. That's the most common that we look at with narrowings of the artery or coronary disease. And there's a couple different ways of doing them. There's a bike or a treadmill where you're hooked up to those little electrical leads, if anyone's had them. That's called an exercise stress test. There's something called a stress echo, where we do an ultrasound of your heart at the same time as you're on a bike. It's a recumbent bike, or you do a treadmill and then you basically hop off right away onto a bed and we do some quick ultrasound pictures. Or there's something called the nuclear medicine or a MIBI scan that does 2 different pictures of your heart with a medication given in between to kind of track the heart. You can also do a CT scan specific for coronary calcium scoring or CT angiography. And every province is a little bit different, to be honest, in how easily that's available. In Saskatchewan, unfortunately, our wait for that is quite long, but in places like Ontario and British Columbia, it's actually quite short, and it's an excellent test there. Or you can look at an invasive coronary angiogram, which is what I do in the catheterization laboratory. So invasive coronary angiogram is also called a heart cath or a left heart catheterization, or a coronary catheterization, or an angiogram. It goes by a lot of words. But it's a test where we actually go inside your heart. We go in through an artery in either your wrist or your leg, and we go up to your heart, and we actually put dye down the arteries of your heart to see if there's any narrowings or blockages there. And it can tell us if your arteries are normal or if they're non-obstructive or obstructive coronary disease there and what we need to do next. We don't usually jump to it as a first test because we would rather do a stress test first instead of having to bring you into the hospital and be invasive. But it is an option that kind of helps you to both diagnose and treat heart disease. Management of heart disease, of course, based on the picture you see at the side, is that prevention is really best. And so the more we can do to prevent you having heart disease, the better it is for everybody. I have enough work, I promise, and I would be very, very happy if I could spend the rest of my career doing primary prevention and didn't have to treat anybody else's heart attacks, but that's a long way away from me. So really looking at our risk factors. So can you stop smoking and can we help you quit? Because I'm not saying it's easy, but we have medications and there's other things that can help as well. And it's the most important thing you can do for your health, not just for your heart health, but your brain health as well. You can control your cholesterol, control your blood pressure, increase your activity level, and manage your weight. And for sometimes this is difficult. So sometimes it's not just your BMI, which is your body mass index, but your measurement of your actual abdomen. We've all heard talks of different body shapes and things like that. And different people are built differently, of course, but we want to really focus on trying to have a healthy weight and really doing that through exercise. And specific to people with psoriatic disease, so people that are on this webinar, prevention is still definitely the best option. But risk factor management is even more important because if you're at risk, we really want to do everything we can to help you be at less risk. And so we want to look at your underlying disease, your psoriasis, and really see how we can help control that. And that's, you guys know this much better than I do, but phototherapy, topical treatments, or systemic therapies, whatever we need to try and get the condition under control and reduce the amount of inflammation that's going on. And we want to do earlier and very regular monitoring of risk factors. So again, getting your cholesterol checked, maybe earlier than the usual 45 years of age that we go to your family doctor. You want to get your blood pressure checked, your A1C to check for diabetes. So all of these are important. And like I said, you might have to ask for them earlier. Checking your height and your weight. And like I said, BMI, we use it, although it's not always the best measurement. And looking at your CRP, so your inflammatory markers. And if you are hooked up with a rheumatologist or a dermatologist, they may already be checking your CRP, but a primary care practitioner can do that with you as well. Mental health. Mental health is super important. It's super important because we know that depression coexists in psoriatic disease. We know that depression coexists with cardiac disease. One of the biggest things that happens after people have heart attacks is that there is depression, and the medications we use for depression increase your risk of heart disease. So it can become a very vicious cycle. So taking care of your mental health is very important, both before and after you have heart disease. And that's actually one of the biggest things with cardiac rehab programs or some sort of group activities, support groups, things like that, is seeing other people that are struggling with the same thing you are or that were struggling and are through it and on the other side. And knowing that you can be there too is a really important part. Because, of course, like I said, multiple links between depression and cardiovascular disease. The other thing that we can do when you're in the hospital, and so this is a picture like trying to kind of show you what an angiogram would look like. We go in through the radial artery in the wrist up to the heart, or the femoral artery in the groin, and we take those tiny tubes literally all the way up to the heart arteries and put some dye down. So if you've been told you have coronary disease, you kind of want to try and figure out, have they told you you have stable disease? In which case you have options for managing it medically or invasively. And so when we talk about medical management, we talked about controlling your symptoms and preventing anything from getting worse. And if we're talking about invasive management, we talk about angiograms. So we take the pictures and we can also often proceed with using a stent to open up a narrowing or a blockage. Or some people do need bypass surgery if they have a number of blockages. The most important thing is that stents actually don't prevent heart attacks. A lot of people think they do. A lot of doctors think they do. So a stent is like a little metal tube that we open up in your artery, but you can still put cholesterol down inside that stent, and that's why they don't actually prevent heart attacks, because they just kind of grow into your body. And so that's why it's important, to, like I said at the start, is really preventing it and looking at what you've got. If you have unstable coronary disease, I hope that means you're in the hospital. And that's when we kind of get more invasive, and we definitely look at doing an angiogram. Because if you're having a big change in your symptoms, a hospital is the right place for you to be. This is to give you an idea of what stents or bypass looks like. When we're looking at stents, like I said, they're these metal tubes that we put into the artery and we inflate them on a balloon, and then the balloon deflates and the stent, that metal layer stays there. And it kind of acts like a scaffolding or a culvert or something to help. Like I said, if you think about plumbing, it's opening up that pipe and kind of keeping it open. Bypass grafting means we take a piece of vein or artery from somewhere else in your body and we do surgery and we make a detour. So we take blood from before the blockage and make a new path for it. We build a new road using a different piece of artery or vein and go around it to give you a new route. And so they're important, especially if you've got lots of narrowing, because we don't want to put a ton of metal in you. And so that's why bypass is sometimes better for people. And so the biggest thing is, like I said, we really want to increase awareness of the risk of cardiovascular disease in people with psoriatic disease. And a lot of times, and it's not fair, I'm not saying it is, but a lot of health issues need to be brought forward by patients. We have a lot of things in cardiovascular disease where people have had to be their own advocates, and the health system is changing slowly to be more patient-centered and recognize the patient voice, but it is slow and it's different in different places. But to know that sometimes you might have to be your own advocate, and that's okay. And like I said, every physician is a bit different, but you can take a lot of charge of your own health and your own risk factors. And I want you guys to feel empowered that this is something that you can also have an active role in and helping with, and that should be something that you get to feel a bit of control, because knowing that you have psoriatic disease, knowing that this means you could have other things, can make you feel like you can't do anything and like you're at risk and like you're hopeless. But that's not true. You can do a lot, and you can actually help take charge, and you can help educate people around you and the rest of us as we share this information and get more people up to speed on how important this is. And it's not just the heart part. Both the heart disease and either the rheumatologic or the dermatologic components of psoriatic disease are super important to manage, because if we can control the inflammation, then you're at lower risk of heart disease as well. So it's not just looking at the heart disease, but it's really looking at all of you and how we treat all of the disease to get you in a best place from a mental health and from a physical health and from a future health perspective. And at that, I wanted to see if, actually I should leave this up to Helen and group and see if we're answering questions now or at the end. I will stop sharing here.
Great. Thank you so much. Yes, we will get to the questions. I think we'll just make sure that we get Margaret's in first, but I know there's already one question in the Q&A. So please, if you do have any questions about what you just heard, put it in the Q&A, and we definitely have time reserved at the end to address them. And I just want to thank you for that presentation. It was so clear and concise and really informative. I learned a lot, and I hope everybody else did. It was very well done. Thank you so much for sharing that. So we'll go back to the beginning. And again, as I was introducing Margaret, as I said, she founded Unmasking Psoriasis, which operates in Saskatchewan. And she's here, has graciously offered to share her experience with how cardiovascular disease has impacted her along her psoriasis journey as well. So I'll turn it over to you, Margaret. You're on mute. Mute, you have to mute, yeah. No, I still can't hear you.
Is that better?
Oh, there you go. There you go. Yeah.
Sorry about that. My power went out just as we were going.
Oh, I wondered what happened. Oh, dear.
Yeah, so I apologize for that. Yeah, I had a really massive heart attack during the COVID too. And I was having this terrible back pain between the shoulder blades. And I really thought it was just because the strenuous work I was doing, that kind of thing. started sleeping on a water bottle and it wasn't getting better. So I called my doctor's office and they said, "Oh, you have to go have a COVID test." Well, that was Friday that I got in for a COVID test. And the COVID doctor said, "I think I'm going to send you for a chest x-ray and blood work." And I thought, well, that's really weird. I got that done. Then, being Saturday, no phone call. I get a phone call Monday morning. "Do not do anything. I want you to go immediately to the ER." Sat in there for a while. And then I was lucky enough to have this fantastic cardiology team that really looked after me and found out that I had been having a heart attack. They did put 2 stents in. And so, again, thank you to the doctors. They were absolutely wonderful. And I remember Psoriasis Day was right after that. And we had a meeting with Helen and Antonella. And the next morning, after my heart attack, I got on the phone with them from my hospital bed. And it was like, oh my goodness. I just felt unreal within the week. And this is what is interesting to me, is my psoriasis cleared up totally. I don't know why. It's come back again since. But it was amazing how well I felt after having a heart attack. But I've changed I go for a walk every day for 4 miles. I really watch the food I'm eating and really, really trying to look after myself. So that's all I've got to say.
Great. Well, thank you, Margaret. Thank you for sharing that. I'm just curious how much you were aware of how cardiovascular disease was linked to your psoriasis. Like, given that we surveyed people who said very few were aware, I'm wondering, even as someone who has been dealing with their psoriasis journey for so long, how much you knew about the risk factors.
I knew very little about that. I was thinking it was more my genes because everybody in my family has had heart disease. And, it was after that. But what really shocked me was I didn't know that the shoulder pain between the shoulder blades would be a heart attack. Because other than that, I felt great. And yeah, so whenever I do anything now, it's like, watch, if you have psoriasis, you are also a chance for these other diseases. And you really, not saying you have to overthink it all, but you have to be aware.
Great. Well, thank you so much, Margaret, for sharing that experience. So we do have a bit of time to get to some questions. So the first one was in the Q&A, and so in the last webinar that we had about psoriatic arthritis, it was mentioned that CRP levels can be normal in patients with psoriatic arthritis, even when inflammation is present. Are there other tests we can ask our physician to order when CRP is normal but inflammation is still suspected, particularly when it comes to helping prevent cardiovascular disease?
There is another measure of inflammation called an ESR, but it's not always offered in every center. And unfortunately, there's no risk scores that actually incorporate it. So the only risk score that incorporates an actual inflammatory marker is the CRP, but there is ESR, which is sometimes used. It's used often in lupus patients. But otherwise, you kind of go from a risk score point of view, even without CRP elevation, you could kind of times your risk by 1.5. But you could try ESR, and sometimes they will do ESR, even places that don't have ESR as a first line. If you have a normal CRP, sometimes you can then ask for an ESR after that. It always depends on the lab, to be honest.
Okay, thank you. So another question. So trying to wrap my mind around all of this and how it all interacts together. We had no idea that there was a connection between psoriasis and heart disease until a couple of months ago. 2 years ago today, my husband had triple bypass surgery. He was diagnosed as diabetic and high blood pressure in his mid-20s, probably psoriasis around the same time. He was 56 when he had his heart attack. So guessing that's more just a comment, but maybe you can just speak to you kind of like that overwhelming experience. Maybe both Margaret and Dr. Eckstein, that patients might, the process they go through when hearing all of this information all at once can be overwhelming.
Yeah, and I mean, it is interesting, like I said, because there is actually some linkages that, like I said, do cause high blood pressure. They cause it earlier and they cause it to be more resistant. And that's specific to certain variations of psoriatic disease and some of the genetics involved. And so, yes, you could be that person, like I said, that's on 4 meds or that had it earlier and things like that. And again, it's not necessarily well known yet at this point. And that the risks associated with inflammatory disease, what we know about that in the last 10 years has increased dramatically, and probably in the last 5 years as well. And so it's not just people, it's the healthcare providers as well. So it's not just patients and people and families and caregivers that are shocked by this information. He said a lot of times it's healthcare providers not realizing why sometimes these people have had many more times that they need medications. I mean, I've had some arthritis patients, autoimmune arthritis patients, who have had very, very hard to manage blood pressure. And sometimes I think that's also because they're in a lot of pain. And so sometimes when you manage their pain, their blood pressure is also better, because that's a big thing. And so if you are always itchy, if you are always in pain, of course, that is also going to make your blood pressure higher. But it's something that everybody is really learning, and our journey through learning more and more about heart disease gets better all the time. And so unfortunately, yeah, I mean, looking back, of course, we can say, oh, well, sure, that makes great sense, but hindsight is always 20/20. So that's why I say it's best to having these kind of things where we help educate the community, where we help educate each other, where we help people to become their own better advocates is super important.
Great. Margaret, do you have anything to add to that? No, you're on mute again. There you go.
I think one of the big things is too that when you're on a medication for psoriasis, and they tell you to get blood work done on regular occasions, get them done. Like, don't fall behind on it. Because I think I would have picked up that I had borderline diabetes at that time. I would have, picked up these different things through those blood work. And I didn't always do mine on time. And so, yeah, when a doctor says, you got to do this, then follow their rules and regulations.
Great. So another question from Bill, who says, did I understand that you say that antidepressive drugs negatively impact heart health? Maybe just touch on that a bit.
So some of the medications used to treat depression and anxiety actually change how our body processes cholesterol. So most of the antidepressive drugs, not all of them, but are associated with differences in your cholesterol profile. And so from that point of view, it's those medications changing how your body manages cholesterol, and then that's the risk from the cholesterol. It's not the drug itself, it's how it impacts your other risk factors.
Okay. And just a follow up to that previous comment. I guess Paula was saying she hit send a bit too quickly, but continuing what she said previously, no one had told her that her husband's psoriasis was a risk factor for cardiovascular disease. And I think you've touched on that it's still kind of emerging information, but they're wondering how important it is to manage his psoriasis, to keep him heart healthy. After his surgery, his psoriasis almost completely cleared up. But and I'm curious as to why that might be, because Margaret mentioned the same phenomenon, but in the last 6 months, it has flared out of control and probably worse than it's ever been. But we can't seem to get anywhere with his family doctor. I'm just wondering about that question about managing psoriasis and how important that is.
I really don't have an answer for why, for Margaret or for anyone, why it would have gotten better after the treatment. I actually don't have an answer for how that has happened. Most of the medications we have for cardiac disease aren't necessarily anti-inflammatory, so I'm not sure why it would clear up like that. But I mean, again, it's the longer you have it and the more severe you have it, increases your risk, given he's already had heart disease. I said, unfortunately, you will probably have to be your own advocate, but your family doctor probably honestly doesn't understand the risks of psoriatic disease and the inflammation to heart disease. And so talking about that, and it depends again, depending on what province you're in, it can be very difficult to get into dermatology or rheumatology and things like that. But trying to, bring them information from, I mean, there's links from a number of organizations now, including Psoriasis Canada, that talk about these risks and things like that. And I would say kind of drawing that to your family doctor's attention, because I know from trying to talk to family doctors about heart valve disease as well, which is another program that I advocate for, they are literally inundated with trying to keep up to date on all the new information that comes at them, because they are your primary healthcare provider for every condition. And so a lot of times they are trying really hard to keep up with all of the conditions and all the new information, but they are just overwhelmed with trying to see people and learn about all the new things. And so I think, helping them out in a polite way and saying, hey, this is what I've seen, this is what I've been learning, we're really worried about this, can we do a bit more to be aggressive about controlling this?
And just another comment, another guest put in that their psoriasis cleared up after heart failure and is now back with a vengeance. So I find that, perhaps worth a study, she said. So that's definitely intriguing. Somebody's asking if there's any suggestions about getting your doctor to order the blood tests that we need, and just kind of in connection with that, another question for both of you on any tips on how you mentioned being your own advocate. So from either Margaret or Dr. Eckstein, any tips on how patients can talk to their doctors to effectively advocate for what they need and want?
See if Margaret wants to answer first on this one, and then I can go.
Oh, it was really strange. Like, I had been, checking my blood pressure regularly, all these different things, and it always came up good. So it was kind of blown away when I was told I was having a massive heart attack. And I don't know if you want to use some of my info on your studies or when you're talking to people, doctor, that, go ahead and use it, because it blows me away. Like, why does it all of a sudden show up when everything has been good before that? I don't understand.
Well, some of that is, so, I mean, and again, some of it is a difference between targets. And so, cholesterol, there's a normal range for cholesterol, and then some people's bodies do handle cholesterol differently. So you can have normal cholesterol. We see it very often in people coming in with heart attacks, that people have had normal cholesterol on their blood tests, but their bodies have put it, I always tell them, they put it in a place where it doesn't belong. And so that changes how we deposit cholesterol, not just our cholesterol level, changes based on smoking. Diabetes changes how you deposit cholesterol in your arteries and you're more likely to put it there. And so there's all these other risk factors. And so if you have them, you may want to have lower than normal cholesterol from the start, or shoot for a bit lower of a target. Blood pressure is tough because the blood pressure targets, again, we have gotten a bit more restrictive too. We've gone both more liberal and more restrictive. So as you get older, we've said maybe we'll let you be a bit higher as blood pressure. And as you're younger, we said maybe we should just really shoot for more like 120 over 80 instead of 140 over 80. And so we've got a bit more restrictive and things like that. Every association has guidelines that say, okay, like I said, for the blood tests, that say, okay, you should start checking cholesterol at the age of 45. You should start checking diabetes at the age of 45 for a man and 55 for a woman. And so we have all these guidelines that are based on the larger population. But we also know that if someone came to me and said, great, I have normal cholesterol, I have normal blood pressure, but everyone in my family has had a heart attack in their 40s, I'm really worried about my risk. We know that some of those people we want to be more aggressive with, and it's not in the guidelines. And that's the thing, is because the guidelines are made to suit the hundreds of thousands of people in this world. They're not individualized for personalized risks. So some of the guidelines now that you will see do actually talk about shared decision making. And so you'll see more and more guidelines that now talk about shared decision making with a patient. If this is your risk, but we're worried. So on your paper, your risk may say you don't need treatment for your cholesterol or things like that, but we're worried because you have a bad family history or you have an inflammatory condition. Maybe there is a benefit to being more aggressive about your blood pressure and cholesterol control and things like that. And so there are those kind of things that are just finally starting to make their way in. And so in terms of suggestions for getting people to order tests that you need, really it is about trying to advocate and say, you know what, this is what I'm worried about. I know that I may not be necessarily needing my cholesterol and blood pressure and diabetes checked yet, but because of my psoriasis, I'm worried I'm at higher risk. Can we look into this? They said all of the blood pressure is obviously easy with a cuff. Cholesterol and diabetes are an easy blood test, and just kind of trying to advocate for yourself and also saying, yes, because like I said, it's not in the guidelines, but I'm worried for reasons X, Y, Z, and I want to be a bit more aggressive about reducing my risk.
Great, thank you. So we have time for just a few more, but somebody's asking what you mean what does it mean when your good cholesterol is bad and your bad cholesterol is good?
Probably means that your good cholesterol, which is usually called HDL, is high, and your bad cholesterol, which is LDL or anything that's non-HDL, is low. And so that's usually a more protective way. So if your HDL is higher and your LDL or non-HDL are lower, that's actually an overall more protective state than if it's the opposite way. So I think if they're probably trying to say that your good cholesterol is higher than normal, and your bad cholesterol is normal or low. So overall, your cholesterol number might be high because your good cholesterol is better. Would be my best guess at it.
Okay, thank you. There is a comment about taking statins as a prevention, but also taking natural products instead that lower cholesterol, and just wondering if you had any insights about natural remedies in heart health.
We don't have a lot in heart health that prove that the natural remedies work. I do think that, I mean, there are some studies looking at coenzyme Q10. There are some studies that look at niacin. The flushing version of niacin is better than the non-flushing version, but of course it makes you kind of red and flushed, obviously. It depends on where your cholesterol panel is. Like I said, at some point, too high of a cholesterol level, those natural remedies aren't going to help. But if you're in that normal range already, taking things like coenzyme Q10 can certainly help. Taking niacin can certainly help. Looking at just being a bit more active can sometimes also help. If you can fit in an extra 30 minutes a day of physical activity, that can help. Statistically, statins are better because statins work not just by lowering your cholesterol level, they also over time have the effect of stabilizing any cholesterol that already is in your blood vessels. And so the reason why statins come out very good in trials, especially in people who've already had heart disease, is because they don't just lower your cholesterol level. Whatever you've already got in there, it makes it less likely to cause a heart attack. So it stabilizes it. It's called a pleiotropic effect. And so that's where, especially the trials that are called secondary prevention, so you've already had a heart attack, that's where statins are really showing a huge benefit. But statins are more effective, but they definitely do have some side effects. And a lot of them are scarier than what actually happens, but some people do have those bad side effects. And so it all depends on how bad your cholesterol really is, whether you can kind of look at those natural options or not. And you can always look at them. You just may need something on top.
Great, thank you. There's also a couple of questions more related, I think, and appropriate for a dermatologist about new and emerging treatments in psoriasis care, as well as a question about psoriasis being a lifelong condition, which, you know, is not your area of expertise. So I'll just say very generally, there are the psoriasis pipeline is quite robust, and there's always new medications that just sometimes take time for approvals and processes, but there are some on the horizon. And unfortunately, as of now, there's no known cure for psoriasis, but a lot of these really effective treatments help patients live with very limited psoriasis, if not complete clearance for significant periods of time. So while no cure, you know, some very, very good treatments. And we're almost at time, so just one more question for you. There's lots of talk in the news and TV commercials that we get through the States and stuff about the benefits of a GLP-1, and you mentioned obesity as an associated condition of cardiovascular disease, and obesity is also a comorbidity of psoriasis. So just wondering about GLP-1s in general and their effect, if there's any other than the obvious of weight management. Because there's some research being done now about GLP-1s and how they affect inflammation, and psoriasis patients might find some clearance from that. So just wondering if that's the same in cardiovascular disease as far as their benefits.
So we do see a benefit in cardiovascular disease. They're difficult to know because as I said, it's reducing your blood sugars, which is helping a reduction in cardiovascular disease. It's helping weight management, which is causing a reduction. They probably are helping with inflammation and reduction that way as well. There are some population health studies going on. There's actually a very interesting group out of Manchester in the UK that is actually looking at population health statistics because they actually have some baseline population health statistics, which we don't really have in Canada. And looking at GLP-1s and trying to see from a primary prevention perspective what the effect that is on population health, but we don't have that large scale data yet from a broad primary prevention perspective. But we assume that they will, but we don't have the primary prevention data we don't have.
Okay, great, thank you. Okay, well, I you know, we're at 8 o'clock. I think we could keep talking about this if we had more time, but unfortunately we're out of time. So I just wanted to take a moment. I popped in the chat a direct link to the online support program that we're hosting on November 19th. If you would like to register, we do limit the number of participants. So if you're interested, to please register early. There's also a feedback form there to please share your insights on this webinar so we can plan for future webinars and get your feedback and input on those. And with that, I want to extend our thanks to both Dr. Eckstein and to Margaret for taking the time out of their evenings to share their insights and their stories. We really appreciate your time. And I just wanted to acknowledge our interpreter who is working hard in the background to translate all this information in real time. As I mentioned, it'll take a couple of days, but these, if you want to revisit these webinars, they will be on our YouTube channel, and you can also visit and see the other two if you weren't able to attend live that we hosted on psoriatic arthritis and the connection between mind health and skin health. So again, we thank our sponsors for making this session happen. Thank you, all of you, for attending, and have a very pleasant evening. Thanks so much.
Thank you.
Thank you.
Thank you.